Welcome everybody for the second action period call for wave 2 of the Understanding Healthcare Disparities and Health Equity in Atopic Dermatitis Patients, Building Knowledge, Confidence, and Change in Primary Care Providers. If these will work. All right, welcome everybody. If you are able to safely in the chat, please share your name, your practice name, and we're switching it up a little bit. If you could share a success or challenge you have had since the program has begun. We've had some good conversations with all of you about how it's been going. We want to share your knowledge with the group as a whole. So if you can, and if you don't mind, sharing a success or challenge you've run into so far. And for the challenges, if people want to chime in and share their thoughts and strategies for helping with those challenges, maybe you've run into the same thing. And we have a packed agenda today. I'm very happy about this. We're going to start with Dr. Treadwell, case by case AD treatment and insurance barriers. Happy to have Addie Brown on from Nationwide Children's Hospital, a pharmacist that will talk to us about atopic dermatitis and insurance coverage in Ohio. Quality of life screening challenges. Again, we've had some good feedback from talking to you on the practice coaching calls. We want Dr. Peltier to share his quality of life screening approach, since he has done the program in the past, and data review with Zainab. And if we have reminders, if we have time, we'll have reminders and question and answer. Okay, Dr. Treadwell, I have your slides.
Okay. What I wanted to talk about is a little bit of the insurance issues that we may see with the children, particularly with atopic dermatitis. And so I'll do it case by case to talk a little bit about some of the things that we might face. Part of why I volunteer to do this is that I've been on the Indiana DUR board for almost 30 years. And so I've seen some of the different challenges. So the next slide, please. So as you've heard us sort of hammer in over and over, is that emollients are very important in terms of the treatment for atopic dermatitis. The patient parent reports to you that the insurance will not cover the cost of emollients. Next slide, please. So, first of all, I often say to parents that the particular brand is not the most important thing. In fact, I was asked on a recent AAP meeting, what's my favorite emollient? And my favorite emollient is what the parent will put on and what the child will let them put on. And so that's sort of the first approach. And then looking at the brands, so generics are fine if there's a particular emollient that the parent does like. They can either find something in the particular store that matches that or generics. I've had other parents tell me that dollar stores are a good place to go. We have emollients on our county hospital formulary, and so patients who are enrolled in that insurance plan are able to get that. I've had parents ask me to use their health savings accounts that they can go ahead and use that to cover the emollients for the children. And I'm going to suggest some advocacy to lobby your state legislature to cover emollients, because they are a very important part of what we do when we recommend treatment for atopic dermatitis. Okay, my next slide. So you have a patient who comes in with atopic dermatitis who has eyelid involvement. And all of us on the call are aware that topical steroids are contraindicated for the eyelids. And so you prescribe a topical calcineurin inhibitor. And I should include, you can also use a PD4 inhibitor, but it's denied by the insurance. Next slide, please. So while you're waiting, you can use a thick moisturizer. Again, the thicker will end up not dripping in the eye. It suggests to the parents that they rub it in. So you can appeal the denial. That's one approach. You can ask for a peer-to-peer. Sometimes when I ask for a peer-to-peer, then that solves everything because they don't want to talk to me. And then be aware of other options in the class. And so each class of treatments should have at least one option on the formularies. Okay, next slide, please. So, and I just picked pimecrolimus. This could be tacrolimus also. So the patient has a prior authorization and they're receiving the topical calcineurin inhibitor. So 2 months later, the parents go for a refill and they're told it's not covered. Certainly in Indiana, the patients are sometimes switched between the HMOs. And the different HMOs may not have the same formularies, or they may not match the fee-for-service Medicaid. So next slide, please. So one of the things that I found is I've had a prior authorization, and then all of a sudden the parents call and say it's not covered. And so sometimes there's movement of drugs from preferred to non-preferred. I actually have a DUR board meeting tomorrow. And what they'll do is give a list of all the changes that they make. It's an hour-and-a-half meeting, and each of the HMOs come and talk. And so I must say I'm not completely attentive to each detail. So sometimes they do get moved. Now, what in Indiana, there's a proposal, but this proposal has been noted for more than a year that they're going to change to one Medicaid formulary. And currently the HMOs are required, and I'll put that in air quotes, to make sure that theirs matches the fee for service, but that isn't always the case. Okay, next slide, please. So advocacy wise, I'd recommend, it takes time, but there needs to be input from providers to be on formulary committees and to be on a drug utilization review board, and also be aware, which I was not aware before being on the drug utilization review board, is that there are pharmacy benefits and medical benefits. And so one of our pediatricians who does a high-risk asthma clinic came to the board to report that if when they changed the inhaled steroids, that patients had delays, they weren't getting the medication when they needed it, and that they ended up in the hospital. And so one of the things I became aware of at that point is that there are pharmacy benefits, which the Drug Utilization Review Board is attentive to. But the fact that these children got admitted to the hospital, that was a medical cost. And so they weren't as responsive, although we eventually got them to agree to a formulary that was sufficient for the patients with high risk asthma. So I would advocacy wise recommend that the providers try to be on these committees, because there needs to be someone to tell the stories about what happens in the trenches. Next slide, please. Okay, any questions? or comments.
Yeah, you can put your questions or comments in the chat. You can unmute if it's safe for you to do so. Hopefully, maybe one of our participating providers has something going on currently that they can run by you, especially those of you in Indiana. Maybe at the provider level, you don't always hear the feedback of the struggles getting the medication in your hand once you leave. That's reality, right?
So I'll go ahead. This isn't necessarily a question. Pat, thank you very much. That was very good. And I think you, I think all as primary care providers experience, it's the same things that you have experienced. This is really more of a question for the group and just, kind of talking about processes and how do you all handle in your office? Like, what's your process? Do you guys have a care coordinator? How do you deal with sort of these medication insurance issues? Who in your office does that? And, what maybe we could kind of have people share and just kind of learn from each other a little bit. So I'll start. So we have in our office, we have a phone nurse that's in our office where our main office is open from 8 in the morning till 8 at night. So we have a phone nurse that typically will do most of the prior auths and will deal with a lot of the medication issues. If it's something we sometimes will employ our MAs to do some things, but we're in the process of we kind of do care coordination sort of piecemeal, right? So we have sort of different people. We're trying to sort of unify it and sort of create a single position. I think probably a couple of our nurses are going to share just from a staffing standpoint, but really sort of having that key person to sort of do that. I was just wondering, maybe one or two, you would maybe just sort of share how you deal with that in your office.
I was just gonna say, usually if we get like a prior auth form, then our medical assistants will go on it and do it. So, but I guess I haven't run into anything like a big issue yet. But I've only been in practice for like a year and a half, so I haven't had to deal with that much of those. But yeah, otherwise that would probably just come to me.
Great, thanks. And Pat, I hope that you all are able to pass that unified formulary. It definitely has simplified things a little bit for us.
Yeah, that has been an issue when patients, they don't even know that they've been changed from one HMO to another. And then all of a sudden, things that we've done to get them medications, they aren't able to get them.
And I'm going to go off on a tangent a little bit, but talking about managed Medicaid, and I'm assuming, and Pat, you can chime in, in Ohio, we actually just sort of have started the next generation of managed Medicaid. So some new plans came on board, but I wanted just to remind everybody, I'm sure you're aware of it, but to let your families know that with the end of the public health emergency, it's been 2 to 3 years since at least, that states have not been required to do redeterminations. So, essentially, federal government said that states could not drop or, could not basically look at, are you still eligible for Medicaid? So obviously that program, luckily has grown and grown and grown. But now that the PHE is ending on May 11th, most states have about a year where they're going to be looking at, do you still qualify to be on your state's Medicaid program? So making sure that, and that's probably going to happen mostly via sort of traditional mail. So making sure that families have their most up-to-date contact information, address, et cetera, with your state Medicaid department. So I know in Ohio, we've got some, and if more than happy, the chapter was, I can't remember if we sent them out or not, but we have some nice flyers that we were working on that have some information on how to contact that. And, I would, same thing in Indiana, check with your local check with your state Medicaid board to make sure that, the probable chances are a lot of the managed Medicaid plans have their own flyers. And so, making sure that your families know about that and that their contact information is up to date.
That's a great point, because sometimes the Medicaid population tends to be somewhat transient. And the public health emergency has been helpful to keep everyone on. And that challenge is about to come forward.
Any other questions or thoughts? Good conversation. Thank you. Okay. Addie, I don't know if we set up a good transition for you for Ohio single PBM and how that looks for Medicaid patients in Ohio, but I have your slides. Thank you.
Yeah, I think it's a great transition. Good morning, everyone. Like Brooke said, my name's Addie. I am a pharmacist at Nationwide Children's in our primary care network. So I primarily work at 2 different primary care locations in the greater Columbus area, and then kind of float where is needed on some other days of the week. So in the clinics, it's really awesome to have a pharmacist, and I feel a part of our team. I am able to not only help with med rec and med education, but also help our medical residents and attendings prescribe covered medications and ensure that our patients are getting their therapies and not having that follow-up appointment and we hear, oh, we weren't able to fill it. So, and not starting those new therapies. So I love being in the clinic, and I'm happy at the end to take questions about that too. But with that being said, we'll jump into the presentation. So Brooke, next slide. Just a disclaimer, this is from my primary care perspective. I've been in practice for about 4 years now, and I did the community residency through Nationwide Children's. And this is all really based on the Ohio Medicaid Unified Preferred Drug List, or UPDL. So my objectives today during this brief presentation are just to discuss the different atopic therapies and regarding insurance coverage, and then understand some available resources to help when prescribing, and then review just some potential insurance issues that Patricia kind of mentioned in her cases too. Next slide. So the treatment targets of atopic dermatitis, as you all know, are on the screen here. So minimizing triggers, we won't really review that today, but using dye-free fragrances and detergents and things like that. But I'll really focus on those 3 bullet points in the middle: moisturizing the skin, reducing the itch, and treating inflammation. Next slide. So starting with our moisturizers and emollients, we know these are important, right? They're the general treatment. We want patients to be using these twice daily, and especially right after bath time. So we want them to have access to them. So our covered agents in Ohio under the UPDL include Dermaphor, both those 106 gram tubes and the big jar with the 454 grams, Minorin cream, and CeraVe moisturizing cream. So I guess on this screen, you don't see Aquaphor. So that is a big one that I see our prescribers, if I don't catch the script going out to the community pharmacy, is sending Aquaphor, and it is not covered. The pharmacy is not going to fill it, or they'll fill it for cash for our patients. So speaking from personal experience, just buying Aquaphor, it was expensive out of pocket. So I try to steer everyone towards, I feel like Dermaphor is really the big emollient we're using in our clinics or sending out to the pharmacies. So those are the 3 that are covered. And as Pat alluded to, it does change often. But at the current moment, those are the 3 that we're seeing a lot. So next slide. So moving in more to our anti-itch. So we really have a couple different antihistamines to use. The first 2 being, more first generation sedating antihistamines, but these are really helpful in kids who their sleep is disrupted due to their eczema, and kind of help the whole family sleep a little bit too. So We have hydroxyzine, both the solution and the tablets are covered. And then Benadryl, same liquid and tablets are covered. And those can be used down pretty far down in the younger ages. But then we also have cetirizine. So that solution is covered. And then the 5 and 10 milligram tablets through Ohio Medicaid are covered. I think an important note is a lot of kiddos want chewables and the chewables are not covered. So I really try to steer our providers away from even sending the chewables because that just leads to a lot more phone calls amongst everyone. So I think a good counseling point is just that the tablets can be crushed and taken with a little spoonful of applesauce or pudding, or they can chew the tablet. So I think that's a good option if you're trying to use a second generation antihistamine like Zyrtec and they can't swallow a pill, but they don't want the liquid too. So next slide, please. So really moving into kind of our main therapies for flares. So luckily, Ohio Medicaid has a lot of, quite a few different options in the different potency classes that are available without prior authorizations and are covered. So really, as you all know, we want to be using these at least twice daily during a flare and only on the affected areas of the skin. So it really started on this screen with class 7 and class 6, so our lowest potent classes. As you know, we really don't want to use these around the face too much, but class 7 and class 6 is where I really feel our providers kind of stick with if we have to use these topical steroids on the face or the groin area in our kiddos. I do want to point out that the fluocinolone oil, that's really helpful if it's kind of more widespread on the body. They can use that oil on their kids. The DermaSmooth, the brand, is the one that's covered. So I really do, and at Nationwide Children's, we use Epic, frequently get a kickback saying fluocinolone oil is not covered. Please complete a PA, yada, yada, yada. And it's just a simple call to the pharmacy saying, hey, can you switch it to DermaSmooth? It goes through Gainwell or Ohio Medicaid just perfectly fine. They switch it. I wait. Oh yeah, it's covered. And then, hang up. So just you can save yourself time by sending the DermaSmooth. Next slide, please. So moving into class 5 and class 4. So really the ones we're using more on the hands, feet, scalp, arms, and legs. Not too much to note on this screen, but I think it's nice that we have a lot of different creams and ointment options. And these on this slide are the ones that are covered without PAs. So just sending them to the pharmacy. If a patient has Ohio Medicaid or one of the managed care plans, they should be covered. So if they're not, that's kind of should start some other questions in our brains of, what's going on? Why are they not covered? Are they refilled too soon, etc. Next slide, please. I didn't really cover too much of the class 1, 2, and 3, as those more are, at least in our primary care clinics, if we're having to go to those, usually it warrants a referral to dermatology. There are a few covered options without step therapy, but there's a link at the end of this slide to go to the UPDL if you are interested in using one of these. But like I said, like clobetasol and those other higher potency, we usually see coming from derm more than from our primary care network. Next slide. So I don't know how many people on this call are aware of Partners for Kids, but I won't go into the details, but it's a great accountable care organization that's really taking care of a lot of Medicaid pediatric kids in Ohio. So they put together their own UPDL, Unified Preferred Drug List, based off of the big Ohio Medicaid one. And they kind of just break it down into common disease states for our pediatrics. And so this is really the atopic dermatitis one. It's just a more easily accessible and readable table, I think, compared to the big clunky Ohio Medicaid one. So this one really shows you the different steroid, the different class, and then what strengths are covered. And with that check mark on the far right-hand column, that's going to be covered right away. And then they do give you some PA options too. I think sometimes our providers, especially ones that don't have a pharmacist or someone helping with insurance coverages in clinic. I think a PA seems like end all be all, but really we can use it and we can get it covered. So I think this is just a more readable table, and I have a link to that at the end of the slides as well. Before I jump into this next slide, I just want to mention that I didn't include many other potency charts, but there are so many out there on the internet. I find that our different providers just prefer, they have their preference of which ones to go to. Personally, I think a great one is on UpToDate, but I didn't want to, sway you. I'm sure you all have your own potency charts that you like to use. So, but jumping into, it's really nice that now we have these non-corticosteroid, like topical calcineurin inhibitors. And as Patricia mentioned, we really use these around like the periorbital area when we can't use the steroids. So pimecrolimus cream and tacrolimus cream, ointment, but they do have different restrictions. So these are not slam dunk covered by Ohio Medicaid. So the pimecrolimus cream, it's actually important to note that it does require a PA, but actually Elidel is the brand name is preferred. So regardless, you have to do a PA, but they do prefer Elidel, if that makes sense. And then it is age restricted, and then it is step therapy. So you do have to state that the patient has failed 2 other topical corticosteroids or give another reason. And usually my reason is, well, they can't use a steroid there. So, I have had great luck, not luck, but success in getting it covered when explaining that on the prior authorization form. And same with tacrolimus. So that ointment is age restricted and step therapy as well, but multiple times too, I've seen it covered with a PA, whether that's through CoverMyMeds or just using the old paper fax system. And then we do have that new PDE4 approved down to 3 months of age. So that's a great option too. It is non-preferred. So I haven't had a provider want to use this yet, and I think it may be more derm referrals and derm might use this more, but you can use it in the primary care network. I just don't know how difficult it will be to get the insurance to cover it. So I haven't had that experience yet. What else on that? I think we're good. Brooke, you can go to the next slide. So I just kind of included this. I think sometimes it's hard to visualize when you're sending out a prescription with a certain gram, how many grams you're sending out. And really, so I just included some common things that might come to mind you might have in your pantry or in your bathroom, but like a jar of peanut butter is 454 grams, which is actually the same size of that Derma4 jar you're sending out to a family. Or the toothpaste is 153 grams. So just kind of getting an idea of what you're sending out to families and maybe how many refills you should put on, or how long you think it should last them. So that's just a little fun size comparison chart. Next slide, please. So I wanted to talk just a little bit about insurance issues because I know this is something that I deal with on a daily basis. So first and foremost, refill too soon. So if your patient's saying, oh, I couldn't refill my Kenalog cream because it was too soon, a couple questions should come to our mind. Well, are you using it correctly? Are you using it as like the directions I provided? Or did the pharmacy bill it correctly, right? So they might have billed it for a small tube that's the size of, like a travel toothpaste. They might have billed for 30-day supply. Well, that's not realistic. So I think one way to try to augment this issue would be in the pharmacy notes, if you have the ability to kind of put which area of the body they're using the topical steroid or other ointment you're sending. That can kind of help the pharmacy determine the day supply to put on the ointment or cream, and hopefully help the patient last through the length of therapy they need. Another one is brand versus generic. So like I mentioned earlier, trying to send Dermasmooth, as we know that's the brand preferred over the generic. and then Elidel over pimecrolimus. But some pharmacies, you know, they're more savvy and they'll just switch it on their own. Some pharmacies won't. So it really depends too. And I think it depends on, you know, pharmacists are really short-staffed these days and don't have many workers for them. So it's hard, right? So I think it's an expectation almost that a pharmacy would switch that on their own, but I don't know if we can expect that right now with everything going on in the pharmacy world. So just a little plug that you might need to call and just kindly ask them to change it to brand. And then for the no therapeutic interchange, what I mean by that is if you send Aquaphor, they're not just going to switch it to Dermaphor for you, most likely. So like I said, Aquaphor is not covered at this time in Ohio Medicaid plan. So just remembering to send the right option or knowing you will have to change it if your resident or someone sends the wrong emollient. For prior authorizations, on the next slide, I did include the link to the PA form for Gainwell, which is the new kind of pharmacy benefit manager for Ohio Medicaid managed care plans. So that is available for the Ohio providers. But so that form is pretty user friendly. You can fill it out on the computer or print it out and fill it out, but really just making sure you put all the information, and then if you are trying to get one of those non-preferred agents covered, just putting in a short explanation on why you want this med, and then what they failed, and kind of the date periods of the length of therapy that they've tried those failed agents. And sometimes if they're, you know, not necessarily failed, but they're using them and their atopic dermatitis is still not resolved, I'll just say, like not enough, or like needs more therapy or something, like needs additional therapy. So you can kind of use your own words and figure that out. And then there's also a step therapy form for the Ohio Medicaid too. So I've had luck just using the PA form and kind of showing the failed therapies and just using it that way, or you can use the step therapy form. So just a lot there, but I feel like being in the clinic every day, I see a lot of those issues on a daily basis. So just wanted to cover that. Next slide. And then here's just some resources. So the Ohio Medicaid UPDL is on there, and then the Partners for Kids UPDL, which is based off that Ohio Medicaid preferred drug list, but just with some more pediatric friendly disease states and how it's organized. So I think that's a great resource if you haven't checked it out. And they also have a lot of great clinical guidelines, not only for atopic dermatitis, but many things. And then just the standard prior authorization form for Gainwell and for Ohio Medicaid. Next slide. And that's all. And I'm happy to take any questions. And I really appreciate you guys having me on the call today.
Addie, thank you so much. Really good information. Any questions from the group, providers that work on the program, that are new to the program, that see this every day, that may have challenges in retail pharmacy? I appreciate very much that the clinics in a hospital have a good relationship with the pharmacy. They can just call. The pharmacies are savvy. They know exactly what to switch it to, but maybe there are some challenges in the retail space or around the PAs that we want to discuss.
I'll just make a comment that thank you so much for bringing up the brand name issues, because I'm at the DUR board meeting. I said, if I write generic and there's a brand name preferred, that the pharmacist got up and said, oh, of course the pharmacist will change that. And I said, no, they don't. And so you have to know that. And so I appreciate you bringing that up, because and having a resource that you have to write the brand name. Mm-hmm. And I had the same reaction, because I said, well, if I just write the generic, if I write the generic name and brand name is covered, they'll switch it over. And patients have told me that that is not the case.
Yeah, we definitely have the same experience, Pat, and which I was very surprised about, because in Epic, which is the EMR that we use, fluocinolone oil parentheses Dermasmooth, unless we check the box of dispense as written, the DAW box, it will not be kind of transferred or covered for the brand name. So it is tricky. You would think that they would switch it automatically, but they don't. I want to echo what Addie said about the refill too soon, and that is an issue that we see often, and that is why it is very, very important to be very mindful of the quantity that we prescribe to the patient. And so if we give them a very small tube, they're going to run out of it very quickly. And very often they will not, even if you provided refills, they will not be able to refill it until next month. They're usually able to just refill it once a month. So we have to be very mindful of the quantity. We have to make sure that it's going to be enough to last them until they're able to refill it again. So I think that's an important point. The other important point that I wanted to make, particularly if you're seeing patients who are coming from a different country, patients whose English is not their preferred language. At Nationwide Children's, we see a lot of patients who have a different preferred language, and something that is I think it's interesting is that the concept of a refill, the concept of a medication refill, is a very American concept, and it is not something that translates into other languages or other cultures. And I can tell that from personal experience. I am from Costa Rica, and where outside of the U.S., you don't get refills for anything. Like even a drink refill doesn't exist. That's an American thing. And so for very often I will see a patient who doesn't speak English as their first language. We give them a really good plan for atopic dermatitis. They come back a couple of months later, and their atopic dermatitis is exactly the same. It's as flared as it was before. And we asked them, what happened? Did the medication not work? And the parents will tell us often, oh no, it worked. I just ran out of it and didn't have more of the medication. And they didn't understand that they actually had refills available at the pharmacy. So spending a little bit more time with those patients and kind of explaining to them how the system works. And if they run out of the medication, they can go back to the pharmacy. I think that's another important kind of practical point to consider.
Esteban, thank you. Can I have either? So I struggle with, and I've heard, I can't remember for either you or Pat. I know one of you have sort of given this pearl before, but how much do family, how much does a child need, right? Like, how, depending on, obviously if you're treating a very isolated area, you're not going to need as much, but what recommendations do you have? How can we best guesstimate like what size tube or quantity to provide a child?
Yeah, that's a great question. And so, of course, it's going to depend a lot on the age of the patient. It's not the same if we're treating an infant versus, a young teenager. They're going to use a lot more. I think it also depends on the potency of the topical medication that we are using. And so, for example, if somebody has, if you're seeing a teenager with head to toe eczema, really bad eczema, we want to use something maybe on the stronger side, like a triamcinolone ointment. That is the only one that comes in a pound jar. And so that a 30-gram tube, it's not going to last them, not even 2 days. And so you wanna go with the larger formulation for them. There are some kind of formulas, and particularly the fingertip unit that can be used to kind of guesstimate roughly how much they're going to need. In one of our previous calls, there were some charts that will tell you kind of roughly how much would somebody need for the face or for the arm, depending on the age. And as you get used to those quantities, then it just becomes a little more second nature to know how much they're gonna need.
Thank you.
Hi, this is Cahill, but I have a quick question. So usually when I give them medication for the eczema, I try to give them a big size tube. However, I don't give them any refills. And I feel like it's something I learned in residency where they say, oh, don't give them any refills because you're not sure how much they're using and you don't want to thin out the skin. So usually I get them to call me when it's done, like they need more. So I have an idea of how often they're using it and if it's well maintained, like if the eczema is well controlled. So is this a situation where we should be giving them refills, or?
I think that's a great question, and you're absolutely right in the sense that we'll often use refills or no refills as a way to limit their use, depending on the potency of the medication that we're using. So, for example, if I'm going to be using a high potency topical steroid, then yes, I would definitely want to limit the amount of refills because we don't want them to overuse it. I would say we're using the low potency topical steroids. If we're in the hydrocortisone, desonide category, the risk of thinning, the risk of systemic absorption is minimal, if any. So you have a lot more kind of liberty to give them more refills. If your practice of having them call when they need more refills, I mean that would still work because that will give you a better sense of how much they're using it. At the same time, it's more work for you and your staff to receive those calls from the parents when they are running out. So I would say if you are prescribing a low potency topical steroid, I think you have more leeway to provide refills. If you're in the mid to high potency, I think a good practice is to limit the amount of refills so that they are not overusing and they're going to have to call the pharmacy, the practice, to request more refills.
Any other questions? Okay, hearing none. Addie, thank you so much. You are welcome to stay on, or you can roll off. That is okay too. I will be sending out your resource links that you put in the slide out to the group, and I appreciate you. Thank you. Okay, Dr. Pelletier, if you don't mind making more robust our quality of life screening challenge conversation that we have started on the practice coaching calls. I know you have some good tips for the group.
Thanks, Brooke. So go ahead, next slide. And I will, in full disclosure, I will say on wave one, this was really, I think, the hardest thing for, I think, both myself and my partners to really kind of integrate into it. Obviously, it's a little bit different than what I think people were used to when we would sort of see a, atopic dermatitis or a rash visit. So I think it's really just, kind of getting it into your workflow and remembering it's there. So just a couple of things. So, if you are already capturing, some of the answers to some of the quality of life questions in another screening, obviously trying to be as efficient as possible. You don't have to go through, the entire thing again if you already have that. I just want to say, I think one of the reasons that I think it's so important, and on some of the earlier podcasts as well as some of our presentations, we sort of have talked about just the mental behavioral challenges and stress that this can have, this disorder can have on our patients and our families. So I think it's just important, just like anything else that we do, that we really sort of want to get the full picture of how things are affecting our patients, which is obviously why we do social determinant screening. It's why we do food insecurity screening, right? It's similar to, if we don't ask, we don't know. So it's why we do maternal depression screening. It's why we do PHQ-9s or depression screening in our kids, so just to really try to get a full picture of what's going on. I think obviously incorporating the screening, it takes some time and you have to be intentional about it. So I think can you go to the next slide? I just can't remember what the next slide is, if it's great. So let's kind of leave that up there for a second. So again, one of the challenges is, right, there are different quality of life screening tools for different ages. So, one of the things you could do is, if you have a patient, in your schedule that's coming in for, a evaluation or follow-up of their atopic dermatitis, reminding whoever, whether it's your medical assistant, your nurse, whoever's bringing that patient back, to pull the appropriate age quality of life screening tool and giving it to the family or to the child if they're older, before you go in to see them. So often that happens with screenings, whether it's a developmental screen, MCHAT, or a depression screen, right? I sometimes don't see it until after the visit and the patient's already left. And then it obviously makes it difficult to sort of address anything that may come up. So I think number one, incorporating it early, getting it so that they can fill it out so that you can review it while you're in the room with the patient. So again, just working with the workflow in your process. And, this is a great, I remember we did this as one of our quarterly PDSA cycles. So, right, trying to figure out what is not working, what do we want it to look like, and then what steps can we take to do that? And then we studied it and sort of worked out the bugs that way. Other things you can do depending on your EHR, we do not use Epic. We have the ability in our EHR to actually to be able to print PDFs from our EHR. So in our protocol for our atopic dermatitis visits, we have sort of links to each of the quality of life screening tools for the various ages. And when I'm in a room with a family, this was before I think we started, giving it at the beginning, regardless, and having our MAs do it, but we can have the providers print them off. So I think that's another option. I think another great option, and it's a little trickier because of the different ages. So it's hard, but I think embedding the questions into your EHR protocol so that they're right there. And one of the things I think you could do is if you had a separate protocol for various ages, just like you probably have not a standard well child protocol, those are going to be age based, and you will utilize the correct one based on the age. You can do the same thing, I think, for the quality of life screening. So you could have under age 4, you could have a atopic dermatitis under age 4, and that would incorporate the questions into the EHR, and you could just ask the family those questions and tick the boxes. Same thing with the older kids and then the teenagers. And then, of course, there's the link for those of you that still need that link. Next slide, Brooke. So again, not going to go over these. Are just some of the questions. You guys have seen some of these. But again, obviously very important as we're in trying to get the full picture of how atopic dermatitis is affecting our patients and their families. Next slide, Brooke. And then there's just the visual for the the young child with sort of the cartoon version. Next slide. So again, we just sort of wanted to bring it up. I know that Brooke is, when she's been doing some of the coaching calls, it's been a thing. So happy to sort of address any specific questions or issues. But hopefully, I would encourage you to first off examine your processes. Consider doing one of your PDSA cycles on it. Consider having your MAs or your nurses giving the form, when they're bringing the patient back, so that they can fill it out and it's ready when you walk into the room, or incorporating those questions directly into your EHR. And I'll see if there's any questions or comments. And happy to have conversations, is Brooke, when you continue to do your every other month coaching calls, I'm happy to, talk offline with a provider or a practice, so you can connect us. So thanks.
Thank you. Chris, one of the live examples we got on one of the coaching calls was maybe not knowing enough about the visit going into the room. So maybe not having the paperwork available. I like your tip about embedding it into the EHR. But if they're not sure that they will be speaking to a patient about AD that day, what's a good suggestion of having a quality of life screening tool maybe more readily available?
Yeah, great question. So again, that goes to our in our EHR. I have the ability to click on a link that'll open a PDF up, and then we print it off, and you can have your MA bring it in. You can walk out and get it, right? So I think the two ways to do that are you stick your head out the door and you ask your MA, hey, can you get me a quality of life screening for the under 4? Or if you have the ability to print it directly from your EHR, that works really well also, I think.
Any other questions? And again, if you think of about any topic at any time, I am an email away and can reach our experts too. Okay, Zainab, I think we will have time for data, and then I will share the rest of the slides in the presentation today.
Yeah, thank you, Brooke. I just wanted to briefly go over some of the data that we have from February. I don't really want to spend a lot of time going over data. I think Brooke and I have a conversation that I think would be a little bit more beneficial or a little bit more encouraging. The data is encouraging, don't get me wrong, but I just feel like, we've had our individual practice calls, and I think that those were really great. We heard the concerns of a few practices, and we tried to incorporate those concerns or those comments into the data collection tool or the survey tracker. And I think moving forward, it's going to be a lot easier for us and for you to be on the same page. So like I said, we'll just briefly go over some of the data. And if you have questions, please stop me at any time, or if questions come up later, then you can definitely send us an email and we can work to get those answered for you. I'm ready for the first slide, Brooke. So really, we understand that sometimes data can be a little bit overwhelming. It can be, presented in a way that maybe you don't understand, or it's difficult for you to conceptualize how the data that you enter is translated into a figure that's presented to you. But the purpose of that, and the purpose of us showing you the data and collecting it, is just so we can track improvement or see where there are problems in terms of how the data is collected, or problems in terms of how how to incorporate the things that we're asking you to, like how to give the families handouts, how to incorporate the quality of life screening like we were just talking about. But we've been talking with a QI consultant or a quality improvement consultant that has kind of given us an overview of how we can merge both of our sides and kind of make that more it's easier to translate and easier for you to understand. So here we're looking at why data collection is important. I know I mentioned that it's used for us to understand what's going on in your practice, but it's also used to measure change and to help us allow you to make sustainable changes. So if you're doing something and the data is not reflecting the effort that you're putting in there, maybe there's something to be changed there. Or if you're doing something right and the data is showing what you would have expected it to, then that's something that you can keep in mind and say, hey, you know what, maybe what I was doing is really working. This is something that's sustainable. This is something that didn't require a lot of effort or a lot of change, and that's something that I can keep doing moving forward. And for us, programmatically, it helps us with future funding and spreading the program, allowing other practices to participate in future waves and so on. Next slide, please. But really, we want to know how this atopic dermatitis or how this eczema is affecting your patient's life, right? So we've heard from a few practices that incorporating the quality of life screening could be a little bit difficult, or that they didn't understand the reason that it was necessary. And really, we just want to advocate for the patient. So we all know that sometimes the time that's allotted for the physician and the family to be together and to speak is very limited. And so, they might use most of their time to address concerns that they're having with their child. But, the physician might not have the opportunity to ask about, or the family might not have the opportunity to tell the physician how, this diagnosis is affecting their child's life, whether it's in school. I know Dr. Faith was talking about in one of our podcasts that especially students that are in their teenage years, or kids that are in their teenage years, feel very self-conscious about very greasy topical ointments. And I can definitely understand that. I'm not very old, but I was, a student once, and I can remember, I had rosacea, and I still do, but I can definitely understand that, sometimes having a cream on your face or on your hands or your skin looking a little bit different can affect you, emotionally. And so, really those quality of life screenings are just for us to track, to see if there's something that the physician can address with you, if you feel like, the ointment is not working, if we can maybe move to a cream that's a little less greasy, or if there's any way that we can, help your child or help the child of the family feel a little bit better or improve their quality of life. And of course, it doesn't just have to do with the way that it looks, but also the way that it feels. Right? It could be painful. They can have a burning sensation. It could be uncomfortable, and stuff like that. And I know that, in the beginning of QI, we didn't necessarily call the data collection tool a symptom tracker. But again, after speaking with our QI consultant, we really want you to have a clear understanding of why we want you to collect that data, right? So I know, we know that you're seeing patients that have already had an AD diagnosis previously, but we really want to know what their symptoms look like now. So that we can see if their symptoms have been improving, if their symptoms really are consistent with the previous visit, or they're going to be consistent with the next visit. So we really want to see how the medication is helping, if it's helping, and how their symptoms are improving or remaining consistent, or potentially getting worse, which we hope that's not the case. And we know that if the patient had a previous diagnosis in a previous visit, then you probably completed an action plan. You discussed with them what kind of medication they'll be taking, how often they need to administer, or how often they need to put that medication on their skin. But really, we want to know if you're looking at their symptoms during this visit, if there had been any changes to that eczema action plan. So are you telling the family, oh, well, it looks better. It's not necessary for you to put the cream 4 days a week. Now you can do it 2 days a week, or only when it flares up, or so on and so on. So again, we changed the data collection tool or the symptom tracker to kind of capture that, to allow you to have a more direct understanding of what the words are saying in the survey or the data collection tool and what you think you're doing in the practice. So we really want you to give yourself credit where credit is due. And if you feel like this is a better way to collect the data, then that's great. If not, if you feel like there's something else that we can incorporate, please let us know and we can work either trying to explain that to you or trying to see what we can do in terms of the symptom tracker or the survey or the data collection tool. And really, you shouldn't feel any type of way about putting your data in there. We're not going to dock points or measure your success based on how your patient's symptoms look or how they're improving. Really, we just want to know what's going on, period. We're not here to say, oh, well, they saw this patient last month and their symptoms looked better, now they look worse and they're not doing so well. No, that's not what we're here to do. We're here to help you. We're here to, walk through this with you to see if you're having any trouble. So please don't feel like that we're judging you or we're judging your quality of care based on that. Yeah, I'm ready for the next slide. And so here again is a brief overview of what the data looks like. And so we again kind of changed the way that we are titling these graphs and the way that we've asked the questions in the symptom tracker, just so that it's a more direct, again, understanding between you and what with the data that you're putting in there. So in February, again, this is not all of February data. Or it could be, but I know some practices were took a little bit more time to enter their data. And so once we get all of that data in, then these figures will be updated for sure. But in January, 90% or 91% of the patients that you saw, you had indicated what their symptoms looked like or the severity of their symptoms. And in February, that's about 88%. It's remaining relatively consistent. And again, these are the patients that are coming in either with a previous diagnosis or a current diagnosis, what their symptoms look like, what the severity of their symptoms are. And again, if, you know, we had another question or another concern in one of our one-on-ones, that, you know, the physician said, well, their symptoms are clear, their skin looks clear. We also gave an option for you to include that as well. If their symptoms are clear and they had a previous diagnosis, but now doesn't look like there's anything on their skin, then we're also giving you an opportunity to include these too. And in January, again, we know that you received some of the documentation late, and definitely that's something that we're keeping in mind. That's not something that you should feel like that we are discrediting you for. That's definitely an error or something to keep in mind for on our end. But looking at February data, it looks like about 70% of patients had completed an action plan, either completed one or had one already in place, and the physician reviewed that with them or edited that action plan with them. I'm ready for the next slide. And again, if you have any questions, stop me. I'm not sure how fast I'm talking. I know we're a little bit crunched on time, but this will only take a few more minutes, so please bear with me. The use of resources or other AD material, we know that we have provided resources to you. We provided a QR code that they could scan that they could receive resources through, or that would display resources for that. And we also know that some practices already have resources available in their practices that were not provided by us. That's definitely something you can share with your patient. And then the quality of life screening, again, this is a little bit where the majority of the practices are struggling. And thank you, Dr. Peltier, for your talk on that. But again, this goes back to the point of us just advocating for the patient, to see how the patient is feeling, to see how, you know, their diagnosis is affecting the family or affecting the patient themselves. And we really want to know if their quality of life has improved or has declined, just so that we have that knowledge and that we could share that with the physician if necessary. So in January, about 14% of patients that came in took the quality or were administered the quality of screening survey. And then in February, that did improve to 34%. We hope to see that line continue to go up, hopefully. But I'm ready for the next slide. Again, I know we went through that pretty quickly, so I don't know, Brooke, if you had anything to add, or if I went over everything that we decided that we wanted to talk about. But if you have any questions, again, please go ahead and ask, or Brooke, you can go ahead and add anything if I missed it.
Zainab, thank you. Yeah, we wanted to capture our good conversation with the QI consultant her goal is always to motivate. So we need to stay motivated. Our job is to motivate you. So Zainab, thank you for that summary. I can pause for questions, and also in the interest of time, we can stop here and I will share everything that we didn't get to today. And I will also share Addie's good resources. Anything else from participants or from the team? Hearing none, we will end the meeting today. Thank you all so much for coming and participating, and we will talk soon. Thank you.